Okay, this is the lecture for anti-hyperlipidemics. So when we're thinking about lipids, we're talking about triglycerides, cholesterol, high-density lipoproteins, and low-density lipoproteins. These are all the things that we're measuring on a lipid panel affected by many factors. Number one, genetics. Number two, diet. That's really the two factors. So, first-line treatment for hyperlipidemia. First-line treatment is the exact same treatment for diabetes if it's not so wildly uncontrolled and the patient's just now coming in for the first time because they're finally symptomatic, is diet and exercise, okay? We know all about that. We learned about that in undergraduate school, and it remains the case. Now, that's perfect world scenario. Real life, I always tell people to diet and exercise, and then I give them medication to help them out. Probably won't be on the board's examination that way, though, okay? There are all kinds of guidelines for the prescribing of lipid-lowering agents. The American Heart Association typically owns the rights to that. They publish a guideline every so often. You can get a copy of it off of the American Heart Association website. I'm not going to quiz you over that, but it really does walk you through the tiers and criteria for lipid management, and it will be something that will be useful to you more so in primary care than it is to me in acute care, because I often initiate a lot of anti-hyperlipidemic treatments, but the care of my patients is short-lived, so much so that the chronic management falls to the primary care providers, okay? So the book starts with the most popular group, the statins, or the HMG coenzyme A reductase inhibitors. So Zocor, actually I don't know most of them by their trade name. I know most of them by their generic name: simvastatin, lovastatin, pravastatin, atorvastatin, the statin drugs, okay? They are very potent lipid-lowering agents. They primarily lower cholesterols. They also lower triglycerides. These are mainstay drugs. Now, there's a lot of controversy. This is not quiz information. This is real-life information. A lot of people don't like them because it seems that they damage the liver. I have seen this. Not all the time. Not all the time. I'm not saying that they don't do a good job. They do. I prescribe them. There's a lot of research that is trying to go on to address this, but it's such a popular medication, and don't ever forget about the medical aspect of medicine. Once someone owns the patent on a drug and it makes money, they're not going to allow anybody else's research to outdo them unless they're owning that research and it's going to make them more money. That's my conspiracy theory. Anyways, statins can actually damage the liver, and that's something you always want to check when you have a patient on a statin drug. Do liver function panel at least once a month, or at their routine visit, or if they have symptoms: nausea, vomiting, abdominal pain, diarrhea. Also, the number one side effect that I really caution my patients about is myopathy, a statin-induced myopathy. It damages muscles. Muscles begin to break themselves down, and patients will experience muscle pain, myalgias, basically all over, and profound weakness. And then they'll complain that they're not urinating, or my urine went from normal to it looks like a glass of tea or coffee. Because all of the proteins and byproducts of the muscle cells, the myocytes breaking down, clogs up the nephrons and the kidneys, and then after, this is measured by creatinine kinase, which is the protein byproduct we're looking at. You will notice that it will be substantially elevated, and I mean like 15,000 on a laboratory report. And that is an indication of rhabdomyolysis, which is simply an acute kidney injury or acute renal failure caused by proteins clogging up the tubes. And this can happen from statin drugs. So if you have a patient, let's say they've had problems urinating, they're describing the color changes, they're not peeing as much, they may be having some flank pains, and you run a urinalysis on them, but you're not finding a urinary tract infection. So when you draw some blood work, and you see in their metabolic panel that their kidney function is impaired above its baseline, and you know your patient takes a statin, you may want to run a laboratory test called creatinine kinase, or some analyzers refer to it as the creatinine phosphokinase. Anyways, if this is substantially elevated, and really if it's even halfway elevated in some of these patients, it adds up and it fits the bill. So statin drugs, well, I thought there was something else this book said that was neat that I was going to tell you, but I guess I dreamed that up. Anyways, that's basically it. They're a very good drug. I always prescribe them to patients when I'm dealing with the heart, hands down. Cerebrovascular disease, stroke. If you have a patient who's had a stroke, always put them on a statin medication, okay? Now, let's talk about triglycerides. People with diabetes, sorry, I'm lecturing from work, and work is trying to find me because I've locked my office door and people don't believe that I'm actually not in here. Anyways, triglycerides. People with diabetes can have very high triglycerides because high blood sugar will drive this. Now, of course, the same reasons that drive cholesterol drive triglycerides. So let's just talk about pure hypertriglyceridemia for the sake of hypertriglyceridemia. 3 things that you can treat this with. Number 1, fish oil. Very, very easy, so it seems, but let me tell you, there is hardly a fish oil supplement or even prescription like Lovaza that will equal what you can get by eating fish every day. So, and most of them do have the fishy breath thing because you're eating concentrated fish oil. If patients want to do that, I tell them eat fish every day, okay? I don't use it all that often until nothing else is working. Okay, so another thing, the phenofibrates, the fibrates, gemfibrozil or Lopid, that's the generic and trade name for the fibrate that I use most for triglycerides. It's pretty effective. There are also medications called bile acid sequestrants. You may have heard cholestyramine or Questran. That's the brand and generic name. They're good for lowering triglycerides in combination with another drug. So if you're starting a fibrate, let's say you've prescribed gemfibrozil, and you're getting good results, but you want better, add a bile sequestrant to it, and it may help. Now, before